CYC is a free channel, presents the Word of God for everyone. Your support will help us to continue the mission. Visit our website, cycnow.com. Even $1 will make a difference.
Hello, and welcome back to another episode from our series on Cyc Md. Today, we will be continuing on our previous discussion from the topic of an obstetricianist gynecologist, and as we said before, is an OBGYN. We have with me Dr. Peter Gerges. Welcome, doctor. Pleasure to have you.
Good to see you again.
And we will be focusing today on the issues of preventative care and things that a pregnant woman would want to keep in mind. So I want to focus maybe and start off with, what is the role of an obstetricianist in prenatal care?
Sure. So really, our ideal job should begin prior to pregnancy or preconception care. In an ideal world, patients who want to get pregnant or are thinking about pregnancy should start to see an OBGYN 4 to 5 months before, so they can get healthy and be on the right supplements and vitamins. But that doesn't happen. Usually patients come to you a couple months into the pregnancy. And our job throughout the pregnancy is to guide, support, and prevent disease or treat disease once we see it. You really want to take care of them all the way through the first, second, third trimester, make sure mom and baby are doing well. We do a lot of screening tests to look for any abnormalities or diseases that could affect the pregnancy. And then we also continue to take care of them postpartum and letting them know what to expect and how to care for, a little bit about how to care for their babies and how their bodies recover from the pregnancy as well.
So what would you say, I mean, I know this is a question many pregnant women either research, ask their doctor, in regards to food. What are the major foods that should be avoided while pregnant?
Well, probably don't want to eat too much given the beta.
Okay.
No, but all jokes aside, most foods are actually safe in pregnancy. There's a few categories that we want to avoid. You really want to be very careful with undercooked meats.
Okay.
You don't want to eat anything that's raw, or, I like my steaks usually medium, but if I were a pregnant woman, I wouldn't have it medium. You want things to be well cooked. That's where cold cuts comes into the picture. Are cold cuts really dangerous? If you're having a fresh cold cut, or a cold cut that's heated, it's probably okay. We worry about uncooked meats that are sitting there for days and then they can grow bacteria. Same thing happens with certain cheeses, specifically cheeses that are unpasteurized, soft cheeses. They may carry certain bacteria that you may ingest, and that can also harm the baby. So that's two major categories that we avoid. Another big one is seafood.
Yes.
Some patients quit seafood altogether. And you don't have to do that. Large seafood, large fish, will usually eat smaller fish, and so they'll have higher levels of mercury, which can be dangerous. Those are the categories to avoid. Swordfish, mackerel, tilefish, fish in that category. Smaller fish, shrimp, etc., you should be able to eat them. Tuna in large quantities is not very safe. In small quantities might be okay. There's actually an excellent website that I refer all my patients to, Figure 4. And that's AmericanPregnancy.org. That website has a lot of information on foods that you can eat, what the levels are that you can eat, how much seafood can I have, what's safe, what isn't safe. And it's usually what I send patients to because they're always nervous and concerned. But all in all, most foods in moderate quantity are usually okay. It's just those select ones that you want to avoid.
And as far as alcohol is concerned, what is your take on that?
Well, there's no good study that shows what level of alcohol is dangerous to the fetus. So in the first trimester, well into the second trimester, I usually tell people to avoid alcohol at all costs. The organs develop up to 8 weeks. Brain and thyroid tissue usually is complete by 15 weeks, and then the remainder of the pregnancy is for growth and development. I do know that some patients may have a little bit in the third trimester, and they say they do fine, but it would have to be my recommendation to avoid alcohol in pregnancy. I feel the same way about smoking. Those are things that could be detrimental to the baby, and we don't know what levels become toxic and at what levels they start to cause harm. So they generally should be avoided.
Yeah. Yeah. Best things just,
Just to stay, right.
you know, take a break from it for a year.
Right.
Yeah. So what activities would you say should also be avoided?
This is a common question. It ranges from patients. I've had patients who will still run marathons in pregnancy. And I've had patients who sit on the couch, don't want to move, they're afraid of hurting the baby. The American College of OBGYN actually recommends 30 minutes a day of moderate exercise. Now what's moderate? The marathon runner, moderate could be 4 or 5 miles.
Yeah.
The woman who's sitting on the couch, getting up and changing the TV could be moderate. So it all depends on your level of physical fitness. And that's something you should discuss with your physician. But moderate exercise is safe. You don't want to be doing dangerous activity. You know, you don't want to be horseback riding, scuba diving,
Right.
you know, things like that. Maybe avoid physical sports or physical activities. But moderate exercise, light treadmill, elliptical machine, maybe a little bit on the bike, those sort of exercises are safe and probably helpful in your general health for the pregnancy.
Would you say it's also helpful in maybe when it comes time for inducing labor? And I mean, I don't know again if that's a myth but I do hear women say like the, you know, moderate exercise, I guess, eases the way for labor.
You're right on point. That is not a myth at all. The healthier you are in the pregnancy, the more strength you're going to have. And labor, specifically the end stage of labor when you're pushing, it's very strenuous work. It's hard work. And so I think if you're in good physical fitness, you will do better. So yes, absolutely. Moderate exercise does help in that regard as well.
Okay, great. I know as women, many women are always concerned about their weight and putting on too much weight during pregnancy. Everything seems good, all the cravings come in.
Right.
And then the woman has in her mind she's eating for two, and she ends up putting on a lot of weight.
Right.
So what advice would you have for women who are concerned about their weight and don't want to put on too much weight, but also want to maintain and be healthy, knowing that they are, you know, giving the nutrition also to the baby?
Sure. That's an excellent question, and it's very important to the climate that we live in now. Obesity has become all over. Everywhere you see there's obesity. It's become an epidemic. And that, you know, the big stuff on the news is with children, obesity, but it's present in pregnant women just as well. And the American College of OBGYN has set out standards and guidelines as to how to treat that. Traditionally, we want women to gain anywhere between 30 to 40 pounds in pregnancy. That has gone away. In a normal woman who has a normal BMI, the goal is 20, 25 pounds, 30 at most. Women that are heavier are actually recommended to gain less, up 10, 15 pounds. But that's very hard to do. And you do need an extra 300 calories for the baby. The real issue comes down to what's your baseline diet. If you're eating 3,000 calories to start with, you're already over the expected limit. So what I recommend is trying to come up with a dietary plan where you're getting 2,200 to 2,500 calories a day, but those calories are more proteins and less fats, simple sugars, carbohydrates. It's very hard to do. It's very hard to do. And I'm as supportive as possible, and I encourage an open communication with your physician or nutritionist. You shouldn't be starving yourself in pregnancy. It's not the time to go on a crash diet, but you should still be very conscious of what you're putting into your body.
Right. What are some common tests that are performed during pregnancy?
So in a normal, totally healthy patient, there are a set of standard tests that we run routinely. They're sort of done during certain stages of the pregnancy. So in the first trimester, at the first visit, we do a blood type and screen. We'll check a hemoglobin hematocrit, which tells you how much iron is in the body, as women usually lose hemoglobin throughout the pregnancy just by expanding volume. We'll check for certain infections that could be dangerous to the baby, specifically hepatitis, syphilis, HIV, rubella. We'll usually send a urine culture. We'll check a baseline weight and blood pressure, and that's checked at every visit. Later on in the first trimester, we typically offer genetic screening, where you do genetic tests, chromosomal tests, evaluations, and they're not always chromosomal tests. They're just evaluations to see if the baby's at a higher risk for genetic abnormality. That's usually done the first trimester and then again between 16 and 22 weeks. At 20 weeks, there's a detailed anatomy scan. And this is usually where most people find out the gender. And that's what they're excited about. But for us, we're looking at different things. We want to make sure the brain is well developed, the heart looks okay, all the bones and structures are normal, the kidneys are present. So that's at 20 weeks. The next big test after that is a glucose challenge test. That's a test for gestational diabetes. Gestational diabetes, with the increase in obesity, there's also become an increase in gestational diabetes. They used to say it's about 2%, but now some studies are showing 8 to 10% of patients. So that's an important test to check between 24 and 28 weeks. And the last test in a normal pregnancy is a culture at 36 weeks. We look for a particular bacteria that could be present. It's called group B streptococcus. The patient won't even know it's there. She'll have no symptoms at all. But if the baby is exposed to it during delivery, they can become very sick. So we check all women. It's present in about 20% of people. It's nothing you can do to get it. It just kind of, due to the change of the hormones, may be present or not. And if it's there, we treat you with antibiotics in labor. Those are the standard tests. There are others that you may do if abnormalities pop up, but all women should expect those set of labs and tests.
Right, so it seems that every few weeks or so, you should be visiting your gynecologist.
Absolutely, and that's a good question you brought up. It's 4 weeks in the first trimester, and then every 2 weeks after 28 weeks. Then usually by 36 weeks on, it's every week. If you go past your due date, they may want to see you twice a week.
So I know many women actually, many women would prefer, obviously, if vaginally is the way to give birth.
Right.
But many times that's not the case, whether it's health-related issues or any other causes, and a C-section would be done, which is a cesarean section. Right. So how common would you say that is?
Interestingly enough, it has become more and more common over the years. And the American College of OBGYN has actually done studies and has tried to implement ways to decrease this rise in cesarean deliveries. The last study I saw stated approximately a 30%, give or take, C-section rate in the United States, much higher than it used to be 20 years ago. And there's lots of reasons for that, and you kind of touched on it. Part of it is the health of women is not as strong as it was before, with women having children at older ages. The size of the baby is an issue. People who've had prior cesarean deliveries, some doctors don't want to allow them to labor. So there are reasons for that.
Right.
But it has gone up. It's up to about 30% now.
So what should a woman expect after a C-section?
So if you had a C-section, the postpartum or postoperative recovery is toughest in the first 2 to 4 weeks. Long term, there's not much of a difference. If you've had a vaginal delivery or a C-section, you take those 2 women 2 years down the road, no big deal. The first couple weeks, the hardest part is moving around because the incisions are across the abdomen this way, and it goes through muscles and nerves. So it's very difficult to move and get up and walk around. And now especially you have a new baby who's going to keep you awake, so they can feel very tired and weak. But every single day it gets better and better. Usually you won't be able to drive for a little while you're on pain control, pain medicine, but it's usually just the incisional pain that's hardest to recover from.
Now, I don't know if this is a myth or if this is true. I feel like we're playing fact or myth.
Yeah, it's like half my job.
So, I hear at times that if a woman does deliver via a C-section, the first child, or every child afterwards is going to be a C-section, or is it possible to deliver a natural birth afterwards?
It's 100% possible to have vaginal delivery after a C-section. One C-section does not always mean a C-section.
Okay.
Now, we're talking about standard, routine cesarean deliveries. Some C-sections are done with a different incision. Those may not be stable enough to allow for labor. So that's in a category by itself.
Okay.
But most women who've had cesarean deliveries at a full term, in a low transverse fashion on the uterus, with the incision on the uterus going this way, most of those women, are candidates for vaginal delivery, and a trial of labor after cesarean should be discussed with them, depending on their risk factors, their reasons for the first C-section, the current pregnancy, their desire and their motivation, the hospital that the physician works in, and their ability to do an emergency delivery if they need it. All of those go into consideration. But the discussion should at least be had, and every woman should determine if she's a good candidate for it.
Yeah. So I want to touch next on the topic of preventative care.
Sure.
What is the purpose of a pap smear?
So the pap smear is a exam of the cervix, where we use a brush and take cells off of the cervix, and we send it to the lab for evaluation. The purpose is to look for precancerous or cancerous cells on the cervix. To sum it up, you're looking to prevent cervical cancer.
Okay.
And pap smears are also very good at detecting the HPV virus, which is the virus that causes cervical cancer. So you definitely want to make sure you get your pap at your required intervals.
And who should receive this HPV vaccine?
The recommendation now is any girl from the age of 9 to 26 is eligible for the HPV vaccine.
So I know you touched on cervical cancer with HPV. What other cancers? I know we mentioned it, but what other cancers are associated with
OBGYN.
OBGYN?
The other main cancers that we may detect or we look for are breast, ovarian, and uterine.
Okay.
Those are usually through your annual exams, and that's another reason to want to go to your doctor annually.
So in regards to menopause, when does a woman go through menopause?
Average age of menopause is 52. If there's a genetic trend to it, so if one's mother or grandmother had menopause later in life, you may also have menopause later in life. If they had it earlier, they may
kind
have
of genetically,
Right.
if you're...
But on average, 52.
What are symptoms? I mean, I'm a little nervous to ask about that.
No, the symptoms, I think they're pretty well known. The most common symptom that everyone complains about, if you find a woman in menopause, she will complain about her hot flashes. She feels hot when everyone else is cold. She's dropping in temperature when everyone else is wearing, jackets. That is the most common symptom from lack of estrogen. But other symptoms include changes in mood, sometimes depression. They may have hair loss, difficulty sleeping, night sweats at sleep, and dryness. So intercourse may be painful. Those are the most common symptoms.
Yeah, I mean, I know some people actually wake up in the middle of the night.
Drenched.
Yeah, and they change because of the
Absolutely.
night sweats.
Very common. Very common.
What are treatment options, or what is available for them to take?
So this is somewhat of a subject of controversy, but menopause occurs from a lack of estrogen. So logically, the best treatment will be replacing with estrogen. But a large study was done by the Women's Health Organization several years ago now, where they compared estrogen and no estrogen. And they saw pros and cons of having the estrogen. And the estrogen helped tremendously with the night sweats and those sort of symptoms, hot flashes. It also helped improve bone health. On the flip side, it caused an increased risk of DVTs, or blood clots, and in certain patients had a significant increase in the risk of breast cancer. And when they went back and studied, the risks were a little bit worse than the benefits. And so now the thought process is we're going away from giving hormone replacement therapy immediately. It's still good, and it's still possible in certain patients that don't have risk factors, but you don't really want to be on it for more than 5 years. So if we're not giving hormone replacement therapy, how do we take care of these hot flashes? Many women use alternative medicines, but the prescription drug that seems to be most effective is actually in the class of antidepressants. And one that I use particularly is known as venlafaxine. Works very well for hot flushes and mood swings. Doesn't work as well for vaginal dryness, but it doesn't carry the risks of estrogen. So there's a bit of a shift in what we're doing to treat menopause.
Well, being a pharmacist, I mean, I have a lot of patients that come and they'll ask me about the over-the-counter products, which is soy, I believe. How, or would you recommend that, and how effective would you say that is?
It's hard for me to recommend or go against those medications. And the reason being is a lot of those medications, soy products, primrose oil, black cohosh, they don't have standards. They're not regulated by the FDA. So they don't have real studies and tests that I can sink my teeth into, and I don't know how much is in this formulation versus that formulation. So it's hard for a practicing physician to go ahead and recommend those wholeheartedly. What I usually tell patients is if you have something that's working for you or something that you want to try, bring it to me. I'll look into it. We'll see what studies are available, and if it seems safe, then sure, no problem. But I do that on an individual basis because the way those drugs are compounded, it's not always uniform. So you're not really sure how much you're getting in each combination. So I try to shy away from them, but if there's a patient that's really struggling, is not a good candidate for estrogen, and the antidepressants are not working, then I'll start to discuss alternative forms of therapy.
Right, because I know a lot of them prefer like natural products, but again, like I guess every manufacturer has a different set of standards or ingredients percentage-wise that they go by.
No, absolutely, and some of them do work well. I'm cautious about which ones they're taking, and I always want to sit down and talk to them and see which one they're using to make sure it's safe for them.
And many times in regards to medicine, everything is patient, individualized.
Right, of course.
It's not
Definitely.
It's not an overall type thing.
Right.
Thank you so much, Doctor.
No problem, my pleasure.
Thank you so much for your time.
My pleasure, anytime. Thank you for having me.
Thank you. We hope you enjoyed our episode today on Cyc Md. We hope we answered many of your questions in regards to women health related issues, pregnancy, menstrual cycles, and also preventative care. Thank you again, Dr. Peter.
You're welcome. Thank you.
If there's any questions, please feel free to email us at www.cycnow.com. Until next time, have a blessed day.